Good afternoon, everybody, and welcome to our webinar today entitled Reducing Morbidity, Mortality, and Healthcare Care Costs Through Adult Immunizations. This event is being co-sponsored by Health Insight New Mexico and the New Mexico Immunization Coalition and the New Mexico Department of Health. A few housekeeping items. Thank you for joining our webinar. And please take a moment to sign in by entering your first and last name and your organization into the chat. If you are joining in groups, please be sure to enter all the names of the individuals in the room. Please note that this webinar is being recorded. All lines except the presenters will be muted throughout the presentation, and we invite you to use the chat feature for submitting your questions. Your feedback and participation is greatly appreciated, and we will try to answer as many questions as we can. When the recording and slides become available, we will send that information to you. The webinar will be available on the Health Insight Zoom page, YouTube page. CME application information will be entered into the chat box and included at the end of this presentation.
Please take a moment to read this paragraph about joint providership. Continuing medical education faculty and speaker disclosure in compliance with the ACCME/NMMS standards for commercial support of CME, Dr. LJ Tan has asked to advise the audience that he has no relevant financial relationships to disclose. Planning committee disclosure. In compliance with the ACCME NMMS standards for commercial support of CME, LJ Tan, David Vigil, Rini Sussman, Maggie June, and Anna Pentler have asked to advise the audience that they have no relevant financial relationships to disclose. Dr. Tan is Chief Strategy Officer of the Immunization Action Coalition and co-founder and co-chair of the National Adult and Influenza Immunization Summit. He has served as a voting member of the Department of Health and Human Services National Vaccine Advisory Committee, where he served on the Adult Immunization, Vaccine Safety, and Healthcare Worker Immunization Working Groups, and chaired the Immunization Infrastructure Working Group. He has served for more than 10 years as the AMA's liaison to the Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices, where he served on the Influenza, Pneumococcal, Zoster, and Adult Immunization Working Group. Now for Dr. Tan.
Great, welcome. I hope everyone can hear me. Just a quick answer on that. Do you all hearing me good?
Yes, we can hear you.
Oh, fantastic. Excellent. Okay. Let me go ahead and see if I can get these slides to advance. And I did. Okay, this is just to confirm I have no conflicts of interest. And also, I do not intend to discuss an unapproved or investigative use of a commercial product or device in my presentation. Again, this is actually an important disclaimer before I move into the heart of the conversation. I think it's important for me to state that I am actually providing opinions as an expert presenter, and that these opinions may not necessarily represent the opinions of or policies of the Immunization Action Coalition, for which I am obviously an employee. And more importantly, also, it does not necessarily represent the positions or policies of the National Adult and Influenza Immunization Summit, which I co-chair with the CDC and with the National Vaccine Program Office. This part is extremely important because I think it would be unfortunate if anybody left this webinar, and my tongue is firmly planted in my cheek here, and said to someone else that they heard in this webinar that LJ said the CDC said that. So I'm disclaiming all of that possibility by essentially saying this is my opinion and my opinion only, and therefore not necessarily representing that of the other collaborators that I have on the summit. Okay, so this is what I'm kind of asked to talk to you all about today. I'm going to kind of spend a little time and kind of go through the morbidity, mortality, and some of the economic burdens of adult vaccine-preventable diseases, hopefully giving you a rationale for why it is so important that we consider adult VPDs as something that we have to prevent. And then talk about some of the coverage rates that we know exist in the country and detail some of the barriers that we're seeing to adult immunizations. I'm going to try to define some of that changing landscape for adult immunizations and how we can probably identify some strategies to improve coverage rates. And in the process of talking about some of these issues, I hope to throw in the middle of my presentation a quick discussion about the new herpes zoster immunization, because I was specifically asked to cover that in today's presentation as well. I'm not going to go into a lot of detail, but hopefully kind of remind everybody that we do have this new herpes zoster vaccine that's out there as well. So without further ado, I'm going to go ahead and jump right into it and start talking about the burden of adult vaccine-preventable diseases. And that's what I'm going to cover over the next 2 slides. I'm not going to go through every single one of these diseases, but just to remind everybody that there is a burden of an impact of adult vaccine-preventable disease among U.S. adults. And in fact, because our pediatric programs have been doing so well, so congratulations to all of you all. I mean, it's the work that you all do on the ground with providers that result obviously in great pediatric immunization coverage rates, and therefore very, very low pediatric vaccine-preventable diseases. Because of that incredible effort, the burden of disease actually is in the adults, and this is some of what I'm going to show you right here. You know, as you can see, with pneumococcal disease, just looking at invasive pneumococcal disease, about almost 31,000 deaths in 2016. 3,700 deaths in 2016, with about 30,000 total cases. A reminder that with invasive pneumococcal disease or IPD disease, 81% of all those deaths are in adults that are 50 years of age and older. And then I also want to put here a point about what we call community-acquired pneumonia. Don't forget that there is a huge burden of disease for community-acquired pneumonia as a result of pneumococcal infection. So about 649 in 100,000 patients are hospitalized annually with CAP. And then of that, about 6.5% of them pass on because of the disease. So there's a fairly significant mortality burden as a result of community-acquired pneumonia as well. Don't need to talk too much about flu. I think we talk about flu a lot, so I'm going to skip that and just talk about pertussis, because I think sometimes we think of pertussis as a pediatric disease. But just to remind folks that of the 15,000 plus cases in 2017 that was reported, about 3,500 were in adults that are 20 years of age and older. So a fairly substantial burden of disease of pertussis in adults as well. And I've got some numbers here for hepatitis B and zoster. And then at the very bottom here, I have numbers for measles. And I put measles up here simply because of the fact that I want to remind everybody, if you don't recall, 2014 and 2015, we had a huge California-initiated, then multi-state outbreak of measles. You all might remember this was the Disneyland outbreak, where it eventually impacted over 8 different states. And for those of you in New Mexico who had to deal with this, obviously my congratulations for working so hard on that, and thank you. But that being said, just want to remind people that this was also the outbreak that allowed California, that served as the impetus for California eventually passing legislation that prohibited what we call personal belief exemptions for vaccination. So California became the 3rd state in the United States to actually prohibit what we call personal belief exemptions. So that was a huge move legislatively on California's part, and was prompted by this outbreak of measles. But then I want to remind everybody that if you actually look at the numbers of that outbreak, 55% of those infections were actually in adults 20 years of age and older. So again, to point out that while we think of measles as a pediatric disease, it really turns out that it's also a disease in young adults as well. And in fact, the fact that all the attention was given on pediatrics when 55% of those infections were actually in younger adults is again a remarkable testimony to the fact that we do really well with pediatrics. We pay attention to pediatrics, but somehow along the line, we forget about adults and adult vaccine-preventable diseases. So again, I'll hopefully showing you here a huge burden of morbidity, huge burden of mortality as a result of vaccine-preventable diseases in adults. I'm going to just focus in with invasive pneumococcal disease, just to show folks that there is actually a group of adults that we tend to ignore, and that is younger adults or young adults with high-risk conditions. And I'm using invasive pneumococcal disease as an example here. If you take a look at this slide, it shows IPD in adults aged 18 years of age to 64 years of age. And it shows you essentially the huge amount of increased risk of invasive disease as a result of pneumococcal infection in these folks with these chronic conditions or these underlying conditions. So if you take a look at the first box with 3 to 7-fold increased risk, these are folks who are 18 to 64 years of age. So not our traditionally what we accept as the older age group, right? These are younger adults. But if you have CVD, that's cardiovascular disease, if you have diabetes, pulmonary disease, kidney disease, liver disease, or alcohol abuse or use, you have a 3 to 7-fold increased risk over a healthy adult of invasive pneumococcal disease. And if you have HIV/AIDS or if you have hematological cancers, oops, my hematological is spelled wrong there, you can see a 20-fold increased risk in IPD. So again, this is a population of folks that we really need to get protected, because when they do get pneumococcal disease, they get invasive pneumococcal disease at a much higher rate. And so something that we want to really pay attention to, this group of younger adults with chronic illness. And this is not just true for pneumococcal disease. You'll see that I'll come back and touch on this with influenza as well. And here's influenza. So just to remind people, influenza has a huge impact of a burden on pregnant women. I'm not going to go through all of this. There is a great review that you can take a look at from Sonia Rasmussen. She published out of the CDC, published in 2012. Unfortunately, I think it's lost at the bottom of this slide here. But it is a review from Sonia that's very well done and talks about this increased risk of complications from influenza in women who are pregnant. And it is because of these increased risks, that's one of the reasons why we have the strong recommendations to vaccinate pregnant women against influenza. But that being said, I just want to remind folks, you think about all this high risk of very severe illness, and you think about the attention that's being paid to pregnant women, younger adults with chronic conditions that can result in severe complications from adult vaccine-preventable diseases, and you think about the press attention, you think about the media attention that we put on this, we realize that obviously compared to some of the more high-profile diseases, we don't put enough attention on adult vaccine-preventable diseases. And if you take a look at some of the other diseases in adults that we pay a lot of attention to, take a look at these numbers. Ebola, we had so much attention on Ebola, right? I mean, the Ebola outbreaks in Africa caused a lot of attention. We actually had 4 cases here. So 4 cases, right? Compared to some of the huge number of cases we get with some of the other adult vaccine-preventable diseases. Lots of fear, lots of media attention about avian influenza, the H5N1 variety. No cases in the United States. 6 months of press coverage on the E. coli 026 outbreak from eating at Chipotle. I think you all might remember that. When you take a look at that and the amount of press attention, 60 cases, no deaths. Compare that to, for example, invasive pneumococcal diseases, where we get like almost a little bit over 30,000 cases and 3,700 deaths, right? And then finally, obviously, Zika virus is something we keep talking about. 5,700 cases through June 16th of 2018. Most of these are travel associated. So a lot of attention paid to some diseases in adults, but clearly the burden of those diseases is nothing compared to the burden of adult vaccine-preventable diseases in the United States. So I've showed you morbidity data, I've shown you mortality data, and I'm hoping that that by itself will be enough to convince you why we have to pay attention to adult vaccine-preventable diseases. And if not, I'm going to then hopefully convince you with some cost data. And so this is the cost data that we have. What we've done here in this study, and this is a publication that was done in 2015 that I was an author on, we took a look at 4 adult vaccine-preventable diseases that you see on the right-hand side of this table. And then we also, using incidence data that are available from CDC, you can calculate in persons 65 years of age and older, and that's what this table is for, the estimated number of cases for each of these 4 vaccine-preventable diseases. So, for example, with influenza, if you look at 65 and older, if you look at the incidence of disease in 65 and older from the CDC, you can calculate that in 2013, which is the year we did this modeling, there would be about 4 million estimated cases of flu. And then based on obviously data in the literature, you can then predict how much those number of cases would cost the healthcare system, and that's what you see in the final right-hand side. And so we did that for the 4 diseases that you see, and the bottom line is at the bottom right-hand side. You can see that in 1 year alone, in 2013, based on census data for those 65 years of age and older, the burden of disease in terms of cost was about $15.3 billion. That's a lot of money. And if you add the population of adults 50 to 64 years of age, you can add an extra $11.2 billion in cost for a total of almost $27 billion in cost in 1 year alone for adults 50 and older because of these 4 adult vaccine-preventable diseases. So that's a lot of money that you can anticipate we could save if we did a better job of protecting our adults against these 4 vaccine-preventable diseases. And I acknowledge no vaccine is 100%, especially in adults, and I acknowledge that that we're never going to get to 100% coverage rates. But if you think about how much money we could save simply by just vaccinating our adults against these 4 vaccine-preventable diseases. And the next data actually shows you data from another publication that was done after ours. This was done by Ozawa and L and company, and they looked at similar diseases. I put this up here because they had slightly more conservative numbers, but they were pretty close to what we have. But they also took a look and said, where do you think the burden of this cost lies? And they showed that unvaccinated individuals are responsible for almost 80% of the financial burden of the cost of disease. So that's actually fairly important to keep in mind. So in other words, again, supporting what I said earlier, that if we could get our adults vaccinated, I think we'll do a huge service to the cost in our healthcare system. Okay, so what I'm hoping that now is I've shown you that there is a cost burden, there's a morbidity burden, and there's a mortality burden because of adult vaccine-preventable diseases. And the great news is that we actually recognize that, at least at the public health level, and we've actually got evidence-based adult vaccination recommendations. And obviously those come from the Advisory Committee on Immunization Practices. And these are the next 2 tables that you're going to see. I think many of you are very familiar with these tables, especially since that's one of the things you're working on is adult vaccines. So I'm not going to spend a lot of time walking us through these tables, except to just remind folks that we do have these schedules available. This is the age-based schedule where you see vaccines on the left and age indications on the right. And then the next is obviously our risk-based schedule, and you can see this gets a little more complicated. Vaccines again on the left, and the different risk conditions for which the vaccines are recommended are on the top again. Again, I'm not going to walk through this because I think you all know this pretty well, but except to remind folks that accompanying these tables are something called footnotes. And these footnotes are important because for one reason, they provide you a lot of the details that accompany these 2 tables, right? For example, if you see purple on this risk-based table, what it means is that for one risk condition plus a second risk condition, the vaccine is indicated for these, it will be indicated. And so therefore, you're going to have to look at the footnotes to figure out what the 2 risk conditions are. And so this is where the footnotes come in handy. You can't read these tables without looking at the footnotes. And also, what is important is that in the footnotes that you see here, one of the things that's very, very clear is that if the indication is in the footnotes of the schedule, then it has to be covered at no copay to the patient by insurance. And this is because of the Affordable Care Act. Just to remind people, the Affordable Care Act has not gone away. It is still with us. And so because of that Affordable Care Act, if the indication again is in these footnotes, it has to be covered at no copay to the patient. So keep that in mind, and that's one of the reasons, I hope one of the motivators for going through and looking through these footnotes, because that will tell you what is covered. So for example, you can see with hepatitis A vaccination, one of the footnotes says very clearly, it can be administered to people who want to simply prevent hepatitis A disease. And so as a result of that, you can therefore give hepatitis A vaccine, and it will be covered by Affordable Care Act. So one of the reasons to look at the footnotes. So we've got evidence-based recommendations, we've got morbidity, we've got mortality, we've got cost because of adult vaccine-preventable diseases. And what I'm going to now quickly kind of go through is the concept that we actually have effective vaccines as well. There's no if and or buts about it. These vaccines are obviously approved by the FDA, and they have recommendations, as you've just seen, evidence-based recommendations from the ACIP. So I'm not going to spend a lot of time running through all the different vaccines, but just to remind people that vaccinations in adults is different from vaccinations in kids. And the reason is simply this, right? I mean, if you think about vaccination in kids, you tend to have a very vigorous population with, a population with a very vigorous immune system that's revving up. And so they tend to respond really, really well to vaccines. On the other hand, when you look at adults, it's going to vary by the vaccine type that you give, and I'm going to show you some examples of that. It's going to vary by the disease outcome that you're looking at. In kids, we tend to look at prevention of incidence of disease, that percentage of disease prevented. In adults, we need to look for more than just that, and I will explain that with flu a little bit later on. And then we also have to look at the age and the health of the person vaccinated. Again, an older adult doesn't have the same vigorous immune system that a kid's going to have. And so as a result, I think it's important to remember that they're not going to have the same vigorous response as obviously a kid will. And so I think that's one of the things I think we have to always keep in mind with when we talk about vaccines. You know, I can tell you as an immunologist by training, the moment I went through puberty and started getting older, my immune system was going downhill already. And so, you know, I have to say, you know, we have to keep that in mind with adult vaccines. So let's walk through this with a couple of these examples that I have here. So for example, vaccine type. Take a look at zoster, and I think zoster is a good one that we can talk about because I'm going to spend a little time on that in a few minutes. We have two zosters vaccines that we talk about. We have the zoster vaccine live, and then we also have something now that the ACIP officially calls recombinant zoster vaccine, or RZV. So that's the new nomenclature for what we call Shingrix. And look at that. You've got two different types of vaccines, right? And it'd be based on a different vaccine that you have, the vaccine type, you have different effectiveness. So, for example, the zoster vaccine live was reported to have a 51% effectiveness against shingles, whereas the RZV, or the recombinant zoster vaccine, has about a 97% effectiveness rate against shingles. So you can now see why there's some confusion out in the public if you're going out there and talking about vaccine effectiveness, just with this one vaccine, zoster itself. Someone's going to say, wait a second, someone's told me that it was 97% effective, and yet someone else tells me it's only 51% effective. So the person who said it's 51% effective was obviously talking about zoster vaccine live. The person who was talking about 97% effective was obviously talking about the recombinant zoster vaccine. So you can see why there's some confusion on the ground with the public if they're thinking about, wait, why are you telling me one thing and then someone else tells me something else, right? So we got to understand that obviously vaccine effectiveness in adults will vary by the vaccine type. And then the outcome is important too. This is a classic one, right? So someone will tell you, you know, back when zoster vaccine live was being given, why do I hear that it's only 51% effective against shingles, but I hear this other number that's floating out there, this 66% effective. So this is where the disease outcome that you measure becomes important. The 51% was against the incidence of shingles. So zoster vaccine live was 51% effective against preventing shingles. But if you look at that severe chronic condition of pain, that pain condition called postherpetic neuralgia that can follow shingles infection, it was 66% effective against postherpetic neuralgia. If you look at recombinant zoster vaccine, the new vaccine that just came out, also trademarked Shingrix, it's 97% effective against the incidence of shingles. That's one health outcome that you're looking at, but it's 91% effective against postherpetic neuralgia. So again, depending on the disease outcome that you're looking at, you get a different effectiveness number. And I think this is where it gets important that we understand this, because these numbers are going to float out there and people are going to say, wait a second, you said one, but someone else said the other. You now have to know they're both right. It just depends on the disease outcome you looked at. Okay, so classic example, if you look at pneumococcal conjugate, if you look at the outcome of pneumonia, what we call community-acquired pneumonia, was 45% effective. But if you look at invasive pneumococcal disease, again, different outcome, it's 75% effective. So something to kind of keep in mind. And influenza is something that's really important. And I'm going to actually punt this conversation to a little bit further down because I actually have some slides to walk us through how we need to start talking and thinking about influenza vaccine effectiveness. And then, of course, hepatitis B vaccine, as you all know, it's a classic where you can show 90% effective if you do a 3-dose series. But as people have chronic conditions or age, where you begin to have a compromise in the immune system, you can see that the vaccine becomes less effective. So again, for adults, depending on the chronic conditions that might be underlying the person or the age of the person, you're going to have a different effectiveness of the vaccine. And this, of course, is very different from kids because if you have a healthy child, there's a less likelihood that that child's going to have some kind of underlying chronic condition that will impact the child's ability to react against vaccines. So you can see why with adults, you got to look at all these different factors, right? You got to look at the age, you got to look at chronic conditions underlying the adult, you got to look at the vaccine type, and you also got to look at the outcome that you're measuring to decide, you know, what's the effectiveness number that you're looking at. So something for us to all keep in mind as we go forward. So with flu vaccine, especially, I think one of the things we need to kind of think about, and this is not just about flu, but it can also be for some of the other adult vaccine preventable diseases, is this idea of looking at vaccine effectiveness in terms of the negative outcomes you prevent. So this is from the 2016-2017 flu season. And because we vaccinated about 45% of the population against influenza in that season, we prevented about 5.3 million cases of flu. We prevented about 2.6 medical visits because of flu. And most importantly, we prevented about 85,000 hospitalizations because we vaccinated 45% in 2016 to 2017. So one of the important things we need to realize is that when you vaccinate against influenza, for example, while you may not necessarily prevent all the cases of influenza, depending on the match, depending on the effectiveness of the vaccine, you can certainly think about all these other negative outcomes that we prevented because we did vaccinate. And I think that's something to kind of keep in mind as we go forward with the way we look at vaccine effectiveness in adults, is think of the other negative outcomes that we averted, even if that person got sick with the disease. I'm going to spend a little time with this slide because I think it's important for everyone to look at this and think about, again, vaccine effectiveness in influenza. So I'm kind of moving a little bit into influenza here because I think it's one of those things that we don't talk enough of. So this summarizes effectiveness data from meta-analysis of influenza vaccination in people with a cardiovascular disease, that's CVD. So if you take a look at the meta-analysis that's out there, it's about 29, influenza vaccination is about 29% effective to prevent acute myocardial infarction in persons who have existing CVD. And it's about 36% effective against to prevent other major cardiac events in people with existing CVD. So remember those two numbers, about 29 and 36% effective, right? So if you think about that, look at the numbers that we do for accepted preventive measures for people with CVD. So if I asked if I could do a virtual show of hands, which I can't, how many people know of persons with cardiovascular disease that are on statin, I would guarantee you 95% of the audience will put up their hands. So we give out statins for people with CVD a lot, right? And if you think about that, if you look at the meta-analysis, look at the data, statins are about 36% effective at preventing major cardiac events in persons with existing CVD. And if you think about antihypertensives, which we give out a lot, that's 15 to 18% effective in preventing acute myocardial infarction in persons with CVD. And smoking cessation is about 26% effective. If you look at those numbers for what we standardly do for people with CVD and compare that with flu vaccine effectiveness, it stuns me that we're not more effectively recommending flu vaccines in people with heart disease. So something to kind of keep in mind. Again, it's a small snapshot of a broader chronic problem we have with adult vaccine-preventable diseases and preventing adult vaccine-preventable diseases through vaccination. I think we don't give enough benefit. We don't give enough attention to the importance of vaccinating against adult vaccine-preventable diseases. Okay, I'm going to talk a little bit here about some of the ideas about other negative outcomes that you can avoid. And I want to thank Jana McElhaney for these slides because I think what I want to talk about here a little bit is about flu. And I think one of the things we forget about with flu, and you hear flu getting a lot of short shrift. You hear flu talk about, it's only 30% effective, it's only 25% effective. Well, I remind everybody, yeah, absolutely. If you're looking at incidence of influenza prevented, it is about 30% varying on season to season, and obviously varying on the age of the patient. Obviously, the younger the patient, the more healthy the patient, those numbers go up. The better vaccine match, those numbers go up. But let's just say we have 30%, right? What we forget to recognize is that with adults, there are two things that happen to them as they get older. They have this process called inflammation, which means that as you get older, this chronic low-level inflammation in your body continues to get worse and worse and predisposes you to infectious diseases. And then not to infectious disease, but to complications from infectious diseases. And then we have this thing called multi-morbidity, which means this chronic underlying conditions that make it worse for us. So for example, diabetes, chronic cardiovascular disease. And what we have is this thing on this slope here called a frailty index. So you start at the top, and as you get older, or as you get chronic conditions, or as you get both older and increased chronic conditions, you begin to decline on this ladder of chronic of frailty. And you can see that we look at the top of the iceberg with regards to our elderly adults or adults with chronic inflammation or chronic conditions. But the bottom of the iceberg is where the impact of influenza occurs. Is that when you get influenza, all of a sudden, these underlying chronic conditions, all of a sudden, your older age accelerates your decline down this frailty slope to the point where you become at that 0.4 levels where you've got a walker. And I always say to people, you know, one of the things that's classic with influenza is that you can have a healthy 70-year-old or a healthy 50-year-old with underlying conditions catch influenza and walk into a hospital, and then after 2 to 3 weeks of battling influenza in that hospital may come out with a walker permanently. So in other words, losing what I call quality of life. And that's important. If you sit down with a 65-year-old person and ask them what really matters to them, a lot of times they will tell you it's not necessarily death from flu, but actually the ability to continue to live a healthy, productive life. You know, people will say, I really want to be able to continue to live independently, to cook for myself, and so on and so forth. And that's one of the things we lose with adult vaccine-preventable diseases, including influenza. I'm going to kind of skip through these slides just to kind of remember that, therefore, what vaccination does is that it allows us to keep the glass half full. And I always ask people, why are you gambling with your independence this upcoming flu season by not getting vaccinated, right? That doesn't make any sense to me at all, because it is such a safe vaccine. We know that if you have chronic illness, we know that if you're older, or we know that if you have both, you are going to get accelerated down this frailty index if you get influenza. So why are you gambling with that independence? Doesn't make a lot of sense to me, at least. And finally, I just want to wrap up on this point and saying that, you know, don't forget pregnant women. Vaccination with Tdap and influenza is highly recommended by the Advisory Committee on Immunization Practices because of the data very clearly shows that. And so don't forget pregnant women on that as well. Okay. And I'm going to spend a little time here now just basically kind of running through a new effective vaccine that we do have, and that's the new zoster vaccine, also trademarked, trade name Shingrix. This adds a second zoster vaccine to our armament to protect against shingles and postherpetic neuralgia. So here are two products that are now on the market. We've got ZVL, or Zostavax. This is a live attenuated version recommended for 60 years of age and older. And then there's Shingrix, which we call RZV, recombinant zoster vaccine. This is an inactivated vaccine, and it is adjuvanted, and it is recommended for 50 years of age and older. So just to remind folks about this vaccine, I'm going to go back one slide here just to remind folks that the ACIP has a preferential recommendation for the use of recombinant zoster vaccine, or Shingrix, over Zostavax or zoster vaccine live. So just to remind folks, there are fundamental differences in the way between recombinant zoster vaccine and the zoster vaccine live. Storage, remember that Shingrix has two components, a vaccine component and a diluent component. The diluent component is the part that contains the adjuvant. And both of these have to be stored in the refrigerator and not frozen. If the vaccine is frozen, don't use it. Remember, it has to be prepared. So in other words, you can't just take it out and inject it. You got to actually reconstitute the vaccine with the diluent, which is the adjuvant. If you don't do that, got no benefit because the adjuvant's not there. All right, so you have to do that right before you inject. So remind your providers of that. Remind everybody this is a 2-dose vaccine that's supposed to be given 2 to 6 months apart. And we understand that there is a capacity supply. There's a supply capacity issue right now. And so if you're confronted with the question, what happens if you've got one patient in with 1 dose versus a new patient that's coming in who has not been vaccinated, and you've only got 1 vaccine left in your supply? What do? You're supposed to complete this 2-dose schedule over vaccinating a new patient with just 1 dose. So you want to complete those 2 doses. There is it's an IM route of injection, and obviously this vaccine can be administered with a bunch of other needed vaccines as necessary. Again, this is the recommendation I already mentioned earlier. 50 years of age and older, 2 doses of Shingrix to immunocompetent persons. Shingrix is not contraindicated for people with immunocompromise, but the ACIP has not issued a recommendation yet. They're looking at that right now. And again, it is preferred to Zostavax for persons 60 years of age and older. One of the things you want to keep in mind, it's become very clear, is that the recombinant zoster vaccine, probably because of the adjuvant, does have a substantial number of what I don't want to call them adverse reactions, although that's the official term, but there are obviously reactions to the vaccine, local reactions, and that's because of the adjuvant. So things like headache, malaise, systematic reactions are there. But that being said, I always kind of remind myself that's for me, an indication that the vaccine is working. The reason why you're having these systemic reactions is because the adjuvant's doing its job and the vaccine is doing its job, and I know it's working. So, so that may be a positive way of looking at some of these adverse reactions. But that being said, I think it's really important to tell your providers that to prepare their patients, knowing that there are going to be systemic reactions because of the adjuvant, and to also remind patients that there is a second dose, and that second dose is necessary for complete effectiveness of the vaccine. So don't because you have this adverse reaction because of the local reactions, don't let that patient say, I'm not coming back, I'm not going to come back. That second dose is required. So just to kind of keep that in mind. Remember, you want to administer the vaccine appropriately, and if you don't, you want to report it. But here are some of the reported errors that have been given to VAERS, which is our Vaccine Adverse Events Reporting System. You want to make sure you kind of take a look at this slide. I'm not going to go through all of these, simply because of the fact that these are errors that have been reported. So remind your providers that this is things that you want to keep in mind of. Okay, so things like, for example, don't give it the wrong route. And the reason for these confusions is because, remember, your providers are used to giving zoster vaccine live, which is very different, right? So remind folks that these are things that they have to keep in mind. Don't, obviously, age, make sure you give the right vaccine. Don't give Shingrix instead of Varivax. Make sure you store it. Remember, you do not want to freeze Shingrix. Remember, you got to go ahead and reconstitute the vaccine component with the diluent component. So these are some of the errors that we are aware of. So things that you want to kind of remind your providers to avoid as you go forward with Shingrix. Okay, so there's a cost burden, there is a mortality burden, there is a morbidity burden. We have recommendations that are evidence-based. We have effective vaccines, including this brand new Shingrix vaccine that's very effective, 97% against incidence, 91% against postherpetic neuralgia. And so, unfortunately, while I would love to say it's a no-brainer, we're all vaccinating our adult populations, we are not. So I'm not going to spend a lot of time going through some of these, but just to highlight a couple of things. So first and foremost, this is data from the National Health Interview Survey from the last 4 years, with the top year in purple at the top. That's the most recent data we have from 2015, and then going down to 2014, 2013, and 2012. I'm sorry, the legend says 2016. That is wrong. My apologies. So if you take a look at the most recent data that we have, I'm going to focus your attention to the bottom three indications: pneumococcal over 65, pneumococcal for high-risk patients, and zoster 60 and older. And the reason for that is because we actually have Healthy People 2020 goals from this. The reason for this is I want to point out is that this is from Healthy People 2020. For folks have said that these are things that we want to achieve. Pneumococcal over 65. Okay, one of the reasons we have a 90% Healthy People 2020 goal. Unfortunately, we are not where we need to be. We are at, if you look at the past 4 years, hovering at about 60%. If you look at pneumococcal at 19 to 64, this is the high-risk group that I talked about before. This is an incredibly vulnerable population for invasive disease. I showed you that slide earlier on, and yet we're only vaccinating them at 20%, and this has, again, been stagnant for the last 4 years. And the Healthy People 2020 goal for that is 60. Finally, at the very bottom, if you look at zoster for 60 and older, the good news is that our Healthy People 2020 goal was achieved. We got to 32.2% in 2015. Yay to us, right? But you know what? What I like to say is, when all else fails, lower your standards. That was meant to be a joke. But that being said, clearly, right, we went from 90, 60 to 30%. So we're at 30%, but I would argue that is not at all a reason to be celebrating. This is flu vaccination for the last 4 seasons. Again, flu is something we're beginning to recognize is very impacted by what goes on in the media, what goes on in the previous season. You can just take a look at that top bar. I'm not going to spend a lot of time, but look at the way the vaccination rates go up and down depending on what we hear. So 2014, 2015 was the season where we had the mismatch, and look what happened to our rates the next year. It went down. Then we push hard, we get everybody back up to 43.6% for last season. So we'll see how for the season before the last, and then we'll see how our most recent data will look for this past season, where we had obviously a very severe flu season. So I think what's really important to recognize is that flu is something that we got to keep talking about. We got to keep mentioning, because we have to continue to deal with the environmental swirling that goes around flu vaccination, be it conversations about effectiveness, big conversations about mismatch of seasons, big conversations about whether the vaccine doesn't work, and so on and so forth. So I think flu is something that we just kind of keep working on as we talk about it. This is some New Mexico data, as you can see here. What I'd like to point out again is that I think, we had that drop from 2014 to 2015, but to New Mexico's great credit, look at that bump that you got the following season. You guys did amazingly well at recovering from all the bad press from the 2014-2015 mismatch. So I think this is something that we want to kind of keep in mind as we go forward, is that again, it's up to you all and up to your providers to continue to emphasize the importance of flu vaccination and getting those numbers, those coverage numbers back up there again. So why is it so hard to vaccinate adults? I'm not going to spend a lot of time on this because I think most of you are very aware of this, because I want to also be able to get to answering some of your questions. But just to remind people, these are the major factors that we hear about, competing social and economic demands. So adults, vaccination tends to be convenience. We just don't do a really good job of emphasizing the importance of getting vaccinated. So the adults they basically say, you know what, we'll get vaccinated when we have the chance, or we'll get vaccinated when we're in the grocery store and there's a discount coupon for getting my flu vaccine. So we need to try to change this convenience mentality to actually a preventive health mentality. And there are challenges. And that the same convenience mentality versus preventive health mentality is carried over into our providers as well, in the sense that in our acute care model for adults, our providers don't have time to talk about preventive measures, let alone talk about adult vaccines. And the giving of adult vaccines is not integrated well into medical care practice because, again, it's in the acute care model. We need to figure out ways to improve that infrastructure so that we can deliver preventive and adult vaccines as part of the adult medical care practice. And then that schedule I showed you earlier from the ACIP, while it's evidence-based, it's complicated. And some of these target groups are really hard to talk about with patients. And then if you think about building clinical decision support into EMRs, some of them, for example, the pneumococcal vaccination recommendation can be very tricky to do. And so as a result, it adds a disincentive, obviously, to providing adult vaccines. And then I bring this up because I think, there are not that many public health resources for adult immunizations. And if you compare adult vaccines to the pediatric model, where we have been so successful, one big reason for that success in pediatrics is that we have a wonderful delivery infrastructure. We don't have that in adults. And in adults, because we don't have a vaccines for children type program, there is a significant burden of disease of uninsured adults getting immunized. It's very hard to get uninsured adults immunized because there is that cost issue. And then finally, there's limited patient awareness and demand for adult vaccinations. Flu may be the one place where we begin to get some traction, but the other adult vaccines, we don't do well. And this is shown in this data here from the CDC, where patients were essentially asked, are you aware that you are recommended any of these 5 vaccines on the left-hand side? And as you can see, flu is the one vaccine where people said, yes, I am aware, and they were correct, versus the other 4 vaccines where there was an absolute lack of awareness as to whether these vaccines were even recommended for them. So it's really challenging when you think about the infrastructure model. You think about the lack of awareness among the providers as well as the public, and those creates obviously barriers to vaccination. So I just want to remind everybody that because of these barriers and because of the low coverage rates, the National Vaccine Advisory Committee did issue a standard for adult immunization practice in 2014. Remind everybody that there was a fundamental paradigm shift with these new standards, basically saying that, we don't care whether you vaccinate or don't vaccinate. If you see an adult and provide care to an adult, you need to be thinking and talking adult immunizations. So basically, that's the new fundamental paradigm. And what it basically says is that all providers of care to adults are to do these 4 things. You're supposed to assess the patient's status for all recommended vaccines at every clinical encounter. Because if you don't assess, you can't recommend, and that's the second one. Once you've done that, you're supposed to strongly recommend the needed vaccines. And basically, the standards basically are saying, we don't really care if you're a cardiologist or an endocrinologist. What we're saying is that if you see an adult for healthcare, you need to recommend the appropriate vaccines to that adult. And then the third, we say you need to vaccinate. Now, if you're a provider because of maybe you're a specialty provider and you've chosen to not stock the recommended vaccine, what we then say, if you can't vaccinate at that same visit, you need to refer that patient to a vaccinating provider. And these standards don't say just send them off and never think about them again. The standards essentially say you need to also validate that they did get vaccinated, and you need to do that and document the receipt of that vaccine by the patient as well. So in other words, you can't just say, Mr. Jones, I recommended you for flu vaccine, go get it done. What they're basically saying is that, Mr. Jones, you're strongly recommended for flu vaccine. I highly suggest you get vaccinated. I don't carry the vaccine. Here is a place you can go that will give you the flu vaccine. And then 3 months later, when Mr. Jones comes back, you're supposed to say, Mr. Jones, 3 months ago, I recommended you for flu vaccine. Did you get it? And hopefully the patient says yes, and then you can document that as well. So again, this idea of providing more attention to the strengths of the recommendations. Here's some strategies for improving adult immunization coverage rates. I think many of you probably know this, but I'm going to kind of highlight them. They come from the Community Preventive Services Task Force, just to remind folks that obviously enhancing access for adults is really, really important. You know, if one of the things we've realized, obviously, is that adults need places to get vaccinated. And obviously, getting access is one way to do that. And part of the access equation is this idea of the client cost. And so here again, I want to remind everybody, if you've got an adult that's under insurance coverage, the Affordable Care Act, which has not gone away, says that these patients are required you know, to be covered at no cost. So just something to keep in mind. Also to remind folks that if you give client reminder recalls, that means recommending that the client come back, say, you know, you are due for your flu vaccine, you're due for your pneumococcal vaccine. If you provide incentives for the client to get vaccinated, either through premiums, deductions, and so on and so forth, those two things, incentives and reminder recalls, really work in increasing community demand for vaccines, and as a result, increasing coverage rates. Healthcare providers, this is where I think all the work needs to be put. I think this is a lot of work that can go here because there's a lot of yield. You know, when you use provider reminder systems, so in other words, that best practice alerts that comes up in the EMR, the electronic medical record, that says, Mr. Jones in front of you is recommended for pneumococcal vaccination. Hey, that works, that kind of provider reminder. When you provide assessment and feedback to the providers that you think you're doing at this rate, but you're actually doing at this rate, that really works in getting providers to recognize how to improve performance. Standing orders really, really work. And when you put all these factors in combination, they work extremely well. So something to think about in terms of improving your coverage rates. This is a slide that kind of summarizes what I just told you. Again, this idea of organizational change. So putting things in place, systems in place that allow vaccinations to occur automatically, routinely, for example, standing orders. Those things have a huge odds ratio for improving adult immunization coverage rates. So I'm going to end by kind of talking about the infrastructure and then hopefully opening things up for questions. I just want to remind people that, you know, if you ask me now, and I've been in adult immunization for more than 20 years now, we're doing better. I mean, it's much better today than it was even 5 years ago. But to remind people that we still have some challenges. You know, our vaccines in those under 65, so they're not covered by Medicare, are covered by private sector. So as a private sector enterprise, the uninsured adult problem still exists, and that number will increase as the Affordable Care Act continues to be eroded, right? So we need to kind of think of ways to protect those issues, those patients. But the other thing that I always talk about is how do we increase the access to adult vaccines? How do we create that delivery infrastructure that is so strong in pediatrics, but doesn't exist as well in adults? What do we need? What data do we need? What political will do we need to do that? And I think the answer actually is in the transforming healthcare delivery system, right? The healthcare delivery is changing in the United States. It's changing from the, you know, the Marcus Welby, the fee-for-service, to the integrated delivery network, so the healthcare system. And I think we need to start talking healthcare system language to help them understand the importance of as they move from volume to value, as they increase their assumption of risk by these healthcare systems. We need to ensure that that value proposition to these systems exists. And there are 5 buckets where if you talk to healthcare systems where they think they want to do a lot of work on, it's these 5 buckets that I show you here: patient experience, chronic disease management, reducing healthcare costs, provider burnout, and managed care bundling. So if you think about all of these issues, those are all issues in which adult vaccines can play an important role. Patient experience, obviously nobody wants to come down with shingles or comes down with postherpetic neuralgia. Chronic disease management, if you think about the impact that I've already shown you of all these vaccine-preventable diseases on people with chronic disease management is a no-brainer for adult vaccines. And obviously prevention reduces healthcare costs. And I would argue if you implement systems changes such as standing orders, you can prevent provider burnout by allowing your provider to focus on things that are more important, more complex, more substantial, and turning a lot of these routine chores of vaccination to obviously accessory healthcare personnel who are just as competent to give those vaccines. So I can argue adult vaccine preventable diseases in all of these bundles, and I think we need to start doing that. And in fact, the summit that I co-chair with CDC and NVPO, we begin to take a look at this. We're now working with healthcare systems. I show you 3 resources that we published in the last year to help healthcare systems understand the importance of prevention and specifically adult vaccine preventable diseases. And I'll show you some of the headlines here. And you have the link in front of you. I'm not going to talk about this. I'm going to basically talk about the fact that with healthcare systems, what they ask you for is return on investment. They're going to say to you, LJ, they're going to say to you, show me that if I do what you've just asked me to do, and I invest in adult vaccines, I'm going to get a return on my investment. And unfortunately, we are still beginning to build that return on investment evidence. And a lot of it's because, we don't do a lot of analysis of the broad benefits of adult immunizations. And the few studies we have in adult vaccines are very confined to very specific direct care cost type issues. And very few of these studies actually take into consideration things like behavior-related productivity gains for adults or community economic externalities, the impact of herd immunity in adults, things like that. And in fact, Ozawa, one of the studies that I cited earlier, states that there is little data on long-term and societal economic benefits such as morbidity-related productivity gains, averting catastrophic health expenditures, growth in GDP, economic implications of demographic changes resulting from vaccination. So this is places where we are beginning to build that return on investment evidence, but we're not there yet. So you kind of have to stay tuned for that. But what we do know is that initial work that looks at these broad implications of successful immunization programs, they show that there is substantial benefits in terms of adult immunizations. And I gave you 2 examples here with HPV vaccination and tetanus vaccination. Okay, I think our challenge for all of us, I think is very clear. We have to translate this economic and cost information to policy and healthcare makers. It's not easy because a lot of policymakers think of prevention benefits as they're not immediate, they're 10 years down the line. So something I do now may not be something I get the return on investment for. But the truth of the matter is when you vaccinate adults, you can get an immediate rapid yield, especially for something such as pneumococcal and influenza vaccination. Flu vaccine in particular, because we give that every single year. When you vaccinate this year, you get an immediate impact on that patient this year. You get immediate productivity gains. You get immediate absenteeism reduction. So those are things that are immediate, and we need to start talking about that. And we need to leverage that patient experience, the chronic disease management, those discussions to help move our policymakers along. I bring up this slide just to highlight a couple of points that we need to continue to work. In the meantime, as we continue to leverage the healthcare systems, we still have our jobs in front of us. So one of the things we have to figure out is how do we drive adult immunization through quality measurement? So I'm delighted to announce that there are 2 new HEDIS adult immunization measures that will come into play in 2019. For those of you who are not aware, HEDIS is the measurement that healthcare plans are held to. The 2 measures are, there's a prenatal or what we call maternal immunization measurement for Tdap and influenza. And then there's also an adult composite measurement that's going to be implemented in 2019 for HEDIS on basically covering the 4 major adult vaccine preventable diseases, flu, pneumo, zoster, and Tdap. So the great news is that there are now quality measures coming up next year. They will be implemented and hopefully that will therefore drive performance as well. I think we also need to think about breaking down barriers that reduce access. We talk about this all the time. Access is important. So for example, Medicare Part B versus Part D, we know that's a huge access barrier for those over 65. And the reason for that is simply because Part D, D as in dog, those vaccines are not treated the same way as Medicare Part B vaccines. So that includes, for example, your shingles vaccine. That includes, for example, your Tdap vaccine. And as a result, because of the fact they're in Part D, and because of the fact that many providers are not Part D in-network providers, a lot of the benefits of the Affordable Care Act goes away, and all of a sudden there's a copay to patients, and that creates a lot of confusion, right? Vaccines are supposed to be free, but not really. So as a result, there's a lot of confusion that we need to think about with regards to breaking down some of these barriers. So I'm going to actually start winding up with this conclusion slide so that I have some time for questions. So I want to remind people the burden of adult vaccine preventable diseases is real, it's large. Many barriers exist, but there are proven strategies to improve those, to break down some of those barriers, specifically system level changes that we can implement. The environment is changing. The transition of healthcare from volume to value gives us opportunities to try to learn how to talk their language, talk about chronic disease management, talk about quality improvement, talk about provider burnout, patient experience. And if we can work our adult immunization conversation into those buckets that these integrated delivery systems are important, I think we can actually begin to change the impact of adult immunizations around the country. A new resource from IEC, just take a look at this. It's a step-by-step guide that you can download for the entire PDF book to start to implement adult vaccinations in your facility or in your healthcare system. And then I'm going to provide you the link right here, and then basically give you some more resources. And I'm going to stop here, and hopefully we'll have some time for a few questions.
Thank you, Dr. Tan, for that interesting, informative, and extremely motivating presentation. I think we all have our work cut out for us. And it has generated quite a few questions already. Since we are at 1 o'clock, we're going to go a little bit over, but if you have to separate from the webinar, I'm going to just quickly tell you about the CME certificate. If you are looking for CMEs, please follow the steps on this slide. You can click on this link or the cme.healthinsight.org. And if you're new to this site, you'll have to register. But if you've already registered, you can log in using your username and password. And once you've successfully logged in, you click on the post tests, select the name of this webinar, addressing the morbidity, mortality, and costs associated with adult vaccine preventable diseases. And then you should receive an authentication email, but if you do not, contact information is supplied. All right, well, let's get to some questions. There were a number of questions about Shingrix. So you had mentioned that there's currently a shortage of Shingrix, and you had mentioned that you would recommend somebody to get their second dose before the provider gives a first dose to another person. What's the rationale for that?
Yeah, there's data from obviously some of the clinical trials that the manufacturer performed in order to get approval for Shingrix that shows that if you give the second dose of Shingrix after 6 months from the first dose, there's actually a decline in the serological response to the vaccine. So in other words, there's a potential loss in the effectiveness numbers that were obviously documented for the FDA approval. So the 97 and 91 numbers drop. So there's a potential that those 97 and 91 numbers would drop. Now, again, the clinical trial doesn't look at that. What we're looking here is serologic data. So in other words, if you wait out 6 months, the immune response, it drops in terms of the antibody. So because of that, the CDC actually has made this recommendation that if you've got a patient in front of you that needs a second dose versus a new patient, give the second dose to that patient who's got the first dose already, so that they can maximize the benefit effectiveness of the vaccine in that patient. Don't have two patients all with just one dose. And I think I saw that question come up, so that's the reason why.
Great, okay, well, thank you. Another question about Shingrix. There's such a high rate of adverse reactions. Is there any recommendation to use an analgesic like Tylenol either prior to or immediately after receiving Shingrix?
Yeah, so absolutely, and that's actually, interesting enough, that's in the general recommendations guidance for ACIP, so I recommend everyone take a look at the general recs, but absolutely pain and comfort management is, I put that as one big broad bullet on my slide, but basically that means using Tylenol, using ibuprofen to kind of reduce the discomfort following administration of Shingrix. So absolutely yes.
Great. So this is a question about flu. And since the people who are over 65 tend to have higher flu rates or complications from flu, how is it accounted for when you calculate the vaccine effectiveness for the general population?
Yeah, so when we do break up, and I don't show this for this slide, but if you look at if you attend a flu presentation I give, you actually can break up the vaccine effectiveness by multiple age groups. So what happens is that we can calculate VE for all the different target age groups, for example, children, adults 50 to 64, adults with chronic conditions, and those over 65. And we actually do have VE for each of those target age groups. When we do the 6 and older, which is the general numbers that I showed you, that's basically a combination of all the data we have for everybody that's not segregated. So it's over the entire sample size. So I hope that answers the question. I think it does.
Yeah, I think that does. So this is a question about Medicare Part D and B.
Mm-hmm.
So I know that vaccines are covered under both Part D and Part B. Is there any policy change on the horizon to move them all to the same one?
Yeah, so there's a lot of talk about policy change. The Adult Vaccine Access Coalition, or AVAC, is in the Beltway group in DC that's working really hard on some of these issues. The challenge with this policy change is that we would have to open up Medicare, or specifically what we call the Medicare Modernization Act, which is what separated the vaccines in the first place back in, I think, 1998 now, I want to say. Don't quote me on that. I might have that date wrong. But the problem with that is that once you open up Medicare, once you open up the Act, there's a lot of concern that it opens up the Act, right? Because then all of a sudden means that other people can come in with changes and so on and so forth. So there's a lot of hesitancy to change the Medicare to make vaccines, adult vaccines, covered in both Part B and Part D, which is where we want. I mean, we want the vaccines covered by both Part B plans as well as Part D plans, because that again improves access, and you know access is critical. But there's hesitancy to do that because of the legislative change that would be required to do that. So in the meantime, what I'm telling people, and this is me, is that we know the Affordable Care Act and we mandates private insurers cover this. So, and we know that they are covering it. So, consider giving your Shingrix to your patients before they turn 65, so that they're covered under private insurance as opposed to Medicare Part D, which we know is challenging.
Great. Okay. Just to clarify, if you're 65 years old, you can receive the pneumonia vaccine, 1 dose, and no subsequent doses thereafter?
No, that is not correct. Thanks for the question, though. So if you're over 65 years of age and you've never received pneumococcal vaccination, you're required to receive 2 doses of 2 separate vaccines. So the first dose you should receive is the pneumococcal conjugate vaccine, or the PCV13 vaccine, and then 1 year later you follow that up with the pneumococcal polysaccharide vaccine, or the PPSV23 vaccine. So I hope that answers the question.
It does. Thank you. We have one more question. Has anyone looked at the reduction in unpaid hospital readmissions for pneumonia after vaccination?
Good question. I don't believe there's been a publication on that. If anyone is aware, please educate me, because I think that would be great data to have. We do know that anecdotally that there's a lot of concern about healthcare systems about readmission rates, and that in fact that's one of the reasons why the increase of interest in vaccinating those over 65, because Medicare is obviously very focused on readmissions within 30 days of discharge. That's why the pneumococcal vaccination coverage of folks being discharged from hospitals is something that we're trying to focus in on, and say, you know what, get these folks vaccinated before you discharge them, so they don't come back in for something else like such as pneumococcal pneumonia, because of the fact that they catch it outside because you didn't vaccinate them. But I would love to know if there's data out there. I apologize, I do not know. I'm not aware that there is.
Well, great. I think that's all the time we have. Thank you so much, Dr. Tan, and thank you to all our listeners. If you are getting your CMEs, you can access your certificate for 30 days from today. And That's all. Thanks so much.
Oh, thank you very much for the opportunity, and thanks for everybody's work out there in the field. We really appreciate it. Thank you.
Bye-bye.